We're going to cover lacrimal system. So we'll go over the anatomy and physiology first. Everybody's familiar with the lacrimal system. Lacrimal gland up here underneath the supraorbital rim, and then the drainage or outflow system, okay? We'll go over it. We'll go over it in more detail. So the anatomy of the outflow system is something that you may be tested on. These little millimeter type measurements is something that they like to ask. So from the punctum, upper and lower, so from the puncta, the canalicular system initially goes vertical for 2 millimeters and then horizontal for 8 to 10 millimeters. Okay, 90% of the population have a common canaliculus and a common internal punctum. So that's where the common canaliculus enters the lacrimal sac. And the valve that prohibits tear reflux or regurgitation back out of the lacrimal sac is the valve of Rosenmuller. The lacrimal sac is about 10 millimeters long, and the medial canthal tendon splits into an anterior and a posterior arm. And those two arms surround and hug the lacrimal sac, okay? The lacrimal sac sits within a bony fossa, and we'll talk more about the anatomy of that fossa because that's another question they like to ask. The lacrimal sac dumps into the nasolacrimal duct, which is 12 millimeters, and then it drains under the inferior meatus of the nose. Here, the valve of Hasner. Okay, that's where that final drainage point underneath the inferior meatus is covered by the valve of Hasner. Which bones make up the medial wall of the lacrimal sac fossa? This was on, I think, one of my OCAPs, and maybe my written board exam, I can't remember, but they actually asked me what bones make up the medial wall of the lacrimal fossa. The frontal process of the maxilla. So it's the maxillary bone and lacrimal bone. Remember we talked about how the medial canthal tendon wraps around and hugs the lacrimal sac. So what should you think of when you have a lacrimal sac mass that extends above the medial canthal tendon? So if you have like a sacrocystitis or inflammation within the sac will distend, but it usually does not go past that tightness where the medial canthal tendon is. But a tumor will go above. And so if that's another classic question they like to ask, if you have a mass that extends above the medial canthal tendon, that should be a trigger word or a red flag for thinking about a tumor. Okay, embryology, just real quick. It's easy. Everything comes from the ectoderm. Okay, so if they ask you what layer of the, it's a neurocrest, is it mesoderm, it's ectoderm. Lacrimal gland and nasolacrimal duct come from the ectoderm. The lacrimal gland begins to function at age 6 weeks, and that's why when infants cry, they don't have, massive amounts of tears until they're of a certain age, usually 6 weeks. The nasolacrimal duct canalization is complete at birth. So, and it goes from cranial to caudal. So the last point of this canalization occurring is at the valve of Hasner, if you recall that anatomy picture. So when you have congenital nasolacrimal duct obstruction, that's usually the point of obstruction. The lacrimal system, you can divide it into a secretory system and an excretory system. Secretory, you think of the lacrimal gland, which, this is another important point, is divided into two lobes by the lateral horn of the levator aponeurosis. So the levator muscle and the aponeurosis is like a big fan. It's like a skirt. You pull up, the skirt is pulled up and then it inserts superiorly, and the lateral horn of it actually divides the lacrimal gland. But the secretory ducts within the gland from the orbital lobe travel through and connect with the ducts of the palpebral lobe. That is why when you do a biopsy, like a lacrimal gland biopsy for lymphoma, we don't biopsy the palpebral lobe, we biopsy the orbital lobe, because if you take the palpebral lobe, you sacrifice all of those secretory ducts. Okay. The other component of the secretory system is the accessory lacrimal glands of Krause and Wolfring. I don't know if they're going to ask you where these things are located, but the glands of Krause are located deep in the superior fornix. Wolfring are located just above the superior border of the upper tarsus. It used to be that they said, the BCSC book will tell you, it used to be that they thought The lacrimal gland was responsible for reflex tearing, and these accessory lacrimal glands are responsible for basal tear secretion, but now the thinking is that all tearing is reflex. I don't think that's going to be on your exam. Secretory system, the afferent pathway, very easy, V1. Okay, the efferent pathway is a little bit more confusing. It's controlled by the parasympathetic system. I just put this in here for completeness. I don't think they're going to have you trace out the pathway of the nerve, but the superior salivary nucleus of the pons exits the brainstem with cranial nerve 7, facial nerve. So that's why when you have seventh nerve issues, especially tumor along the pathway of the facial nerve, sometimes you can get lacrimation problems. Hops off the facial nerve as the greater superficial petrosal nerve, synapses at the sphenopalatine ganglion, and then enters the lacrimal gland via cranial nerve V2. So starts out with cranial nerve 5, hops on 7, back on 5. The secretory system in the end produces the tear film. And we all know about the 3 layers of the tear film. The outer layer is the oily layer, and the oils are secreted by the meibomian glands. The thick intermediate aqueous layer, that's where your secretory, your lacrimal gland, and the accessory lacrimal glands make the tears. And then the inner mucinous layers made by the conjunctiva goblet cells. So 10 to 20% of tears evaporate, maybe more depending on climate like we have here in this dry climate. A lot of patients we see have dry eye issues. But the book says 10 to 20% of tears evaporate, and the rest should get dumped into the excretory system. And then there are these different theories of the tear pump and how it works. But in general, I think they still say this for the purposes of the boards, but the blink system and the compression of the eyelids from the orbicularis muscle, and the fact that the medial canthal tendon wraps around the sac is the tear pump theory. So when you blink, there's positive pressure, forces the tears into the canaliculi. When you open your eyes, there's a negative pressure, so the tendon relaxes, and the lacrimal sac is able to suck the tears in. So positive pressure when you close and push the tears in, negative pressure when you open, tears get sucked further down through the lacrimal system. They make a point to tell you that there's a difference between lacrimation and epiphora. I don't think you'll be tested, but just for purposes of sounding educated, I think it's nice to know that. Lacrimation is increased secretion. Epiphora is decreased drainage. And so there are various tests that they will test you on how do you evaluate for secretory versus excretory system problems. So if it's a problem with tear production or secretion, first hint you'll have is when you look at the ocular surface and you look at the tear film. If there's mucin or debris, then you know the tear film is unhealthy and it may be a secretory issue. If there's trichiasis or ocular surface irritation, then it's causing reflex tearing and triggering more secretion. So that's not difficult. That's pretty routine. The tear breakup time is, I guess, a more formalized way to think about it. If you have a poor tear film, the tears will break up faster. So less than 10 seconds says that it's an abnormal tear breakup time, and usually it's the mucinous layer, the goblet cell mucin, that's not normal. Schirmer tests, something that they like to ask you. Schirmer 1 is, so does everybody know what a Schirmer test is? Those little paper strips that, it looks very, very barbaric, but those little paper strips that hook into the inner corners of the lower eyelids, and you tell the patient to sit there for 5 minutes, and then you come back and you see how soaked the little paper strips are. Schirmer 1 is when you do this without any anesthesia. So you're measuring all tear secretion, basal versus reflex, or in the new theory, everything's reflex, so who knows. But all you need to remember is you're doing the Schirmer's test without anesthesia. Greater than 15 millimeters of soaking on that little strip is abnormal. Okay, Schirmer's 2 is when you do that and you sit and you irritate the inside of the nose and you really make them tear, but I don't think that's not usually tested. Practically, in the office, what we do is the basic Schirmer test. So you anesthetize the conjunctival fornices first, and then you put the little strips in, wait 5 minutes, and see how much tear you have. Again, greater than 15 millimeters is abnormal, And conversely, when you're testing for dry eye, less than 10 millimeters start to suggest some dryness. Other excretory, that was secretory. Now we're going to go to excretory system tests. The dye disappearance test is very easy to do. It's practical. It's what we do mostly in the office, and you can do it on little kids too. Whereas you couldn't do Jones testing on little children. So the dye disappearance, you just put a drop of fluorescein, and you wait 5 minutes, and you see if there's still dye in the tear lake. If there is, then that suggests an abnormality in the tear drainage system. So pretty straightforward. It's very helpful if there is one side that has some kind of a drainage problem and the other side is normal, you can really see a difference in the tear lake after 5 minutes. I have, on one of my OCAPs, I was asked to distinguish between Jones 1 and Jones 2. So Jones 1 is when you instill the fluorescein, and then you wait 5 minutes and you look for the dye in the nose. You look for the dye in the nose under the inferior meatus. You just stick kind of a cotton tip in there. If you see any dye, then it's normal. If you don't see any, then you have to further distinguish whether this is a functional obstruction or a anatomic complete obstruction. That's when the Jones 2 comes in. So Jones 1 is done first. Jones 2 is done if you don't recover dye after the Jones 1 test, okay? So if you don't recover dye, what you do is you flush the nasolacrimal system with some saline. And if you see dye, then you know it's not a complete obstruction because it can get through, but it just requires you to push some fluid through it so that you think of a functional obstruction. If you don't see the dye, even after you flush with some saline, then you know that it's a complete obstruction. Okay, so that's Jones 1 and 2. I don't think they'll ask you about scintigraphy, which is basically a radionuclide test for like a functional test of the nasolacrimal system. I don't think they're gonna. We don't do that. I've never seen one. Or a dacryocystography is just an X-ray, plain film X-ray, after you inject some radiosensitive dye. Well, we do obtain our CTs and MRIs to look at the lacrimal drainage system when there is an abnormality. I think the only thing you need to know about congenital lacrimal disorders are congenital nasolacrimal duct obstruction and dacryocystocele. Okay, so congenital NLDO, really common. Half of babies at birth have some kind of NLDO, and it's from the imperforation of the valve of Hasner. Remember, the system canalizes from cranial to caudal, and the last point of canalization is that valve of Hasner. So 50% of them have it at birth, a third are bilateral, and a 90% resolve in the first year. So there is some debate, how early do you go into probe and all of that, but I think, and Luke, you can correct me if I'm wrong, but I think the BCSC teaching is still that you wait 1 year before you probe. You wait for this 90% resolution. So if a parent comes in and baby's got mattering and watering, you can tell them, you can try massaging right at the area of the lacrimal sac so that the mucus doesn't collect in there and form a environment for bacterial infection. So you can tell them to massage. And that'll usually tie things over until it resolves on its own, until that valve becomes perforate on its own. Like I said, some controversy about when to probe. I think in general, the answer is you wait till after age 12 months. At the time of probing, if the inferior turbinate is large or is sitting up against the drainage point, the valve of Hasner, then some physicians will choose to infracture, which just means you put in a freer elevator or some kind of instrument and you just bend it or fracture the turbinate. It's not like thick bone where you have to take a hammer and chisel to fracture it. You just move it out of the way. And then there's controversy about silicone intubation. Some people will intubate on the first go around. I believe the book tells you definitely do silicone intubation if it's a repeat probing or if there has been a dacryocystitis or some kind of infection. But if it's a primary probing, you don't need to do silicone intubation. A dacryocystocele is basically closure at the valve of Rosenmuller and the valve of Hasner. So you have closure of the lacrimal sac and there's some retained amniotic fluid or mucus in there. Usually one of these valves, both of these valves open spontaneously, and you just need to treat the patients with warm compress, massage, maybe prophylactic antibiotics to get them through the acute period until the system canalizes normally. So just supportive treatment. But if there's no response to therapy, or if it becomes infected, then that's an indication to go in and probe. Usually just opening up those membranous obstructions, those soft obstructions, will allow the retained mucus or amniotic fluid to drain, and then baby is okay. Acquired disorders, punctal condition, punctal stenosis, usually what we do is we just snip procedure, open up the punctum, and then put silicone tube into the system just to make sure that the system heals open so that it doesn't scar back closed as it heals. Punctal malposition, you saw Kathy's lecture about the medial ectropion. That's a surgical problem. You just have to put it back into position. The punctum has to sit against the tear lake in order for the tear pump system to work. Okay. Dry eyes, we all hate dry eyes, but punctal plugs, you can close the puncta with thermal cautery. You can suture the punctum closed. Once you've proven to yourself that it doesn't cause overflow tearing. So we initially close the puncta using punctal plugs, and if the patient can tolerate it, then you can think about more permanent procedures if the patient desires. Canalicular obstruction is something that we see not infrequently. Trauma is a cause of the canalicular obstruction. Sometimes it's left unrepaired, or the canalicular laceration is repaired, but the system still scars and heals and closes. Toxic and meds, often we'll see it in patients who are on glaucoma drops. I think the classic medications that your book will tell you is idoxuridine and those types of and other chemotherapeutic agents. But so I usually, when patients come in with obstruction of the canaliculus, then I'll ask them questions like, have you ever been on chemotherapy, especially for breast cancers, or, are they on glaucoma drops? Have they had trauma? The classic viral cause of canaliculitis or canalicular obstruction that they will ask you, the viral cause is going to be, the answer is herpes. Okay. Autoimmune causes, of course, the pemphigoid and the Stevens-Johnson, those classic mucous membrane scarring diseases. So if it's a partial obstruction, sometimes you can get away with just probing and putting a silicone tube through it, leaving the tube in there for a couple of months, and hopefully the system heals open. If it's a complete obstruction, it's really, really unusual that you'll be able to reconstruct this tiny little membranous system. So what you end up having to do is to place a Jones tube, what's called a CJDCR, or conjunctival dacrocystal rhinostomy. So this is a Jones tube, usually a Pyrex tube. Sometimes they can be frosted with a rough outer coating, so for the tissue to retain it. But there are different varieties. Basically, you're just bypassing this entire lacrimal drainage system, putting the tube into the medial inferior fornix, and just hoping that the tears will well up and drain in by capillary action. Canalicular trauma, we see a lot of that. The inferior canaliculus is more important. So some people will just leave a severed superior canaliculus unrepaired. But if it's an inferior one, you definitely want to at least try and repair it. We try to do this within the first 24 hours, but a delay in surgery, especially if you just can't get operating room time or whatever reason, is okay, but you have to keep that area really lubricated. Just goop it up with ointment, because if it dries out, that canaliculus membrane will just retract back into the tendon, and you'll never find it. So there are different ways to repair these. You can use a monocanalicular stent, so you can place a monocanalicular silicone tube that, if you can find both ends, it sits in the punctum, and then the other end just dangles in the lacrimal sac. You just suture the tissue around the canaliculus. Some people actually suture the canaliculus, but basically you oppose these two cut edges and then leave that tube in there, take it out after several months' time. you can do a bicanalicular system, which is the silicone tube. There's a little loop here, enters the severed end as well as the normal end, and both ends of the silicone tube travel through the lacrimal sac and come out the nasolacrimal duct. Perhaps it's the more conservative, safe thing to do. Perhaps a little bit better retention rate if you do a bicanalicular silicone intubation. And the other reason to do it is if you can't find this proximal cut end, you can use a pigtail probe, go in through the intact end, circle around into the lacrimal sac out and into the common punctum, assuming they have a common punctum and common canaliculus, and then your instrument should come out the severed end of the canaliculus. But anyhow, you do want to leave a silicone tube in there so that the system heals open. Okay, this is definitely a board question. Most common organism causing canaliculitis is Actinomyces israelii. It's a filamentous gram-positive rod. I don't know why they ask you that, but very popular. Of course, basically every other organism has been found as a cause of canaliculitis, but Actinomyces israelii, definitely cement that into your memory. You'll see a dilated, pouting punctum. You may get some reflux when you apply pressure in the area. When you probe the system, it feels gritty. It doesn't feel smooth, not like a soft stop or membranous obstruction. The whole thing just feels very gritty. Treatment is massage. You can irrigate with penicillin or topical antibiotics, depending on what the organism is. The most common thing, of course, is nasolacrimal duct obstruction in the adult, which occurs for lower down in the system. They can present with all sorts of pain and discomfort, watering. Sometimes it develops into a dacryocystitis from an obstructed lower system. And again, the tears and the bacteria that are normally in your tear leg will get into the lacrimal sac, not be able to dump out of the nose, and then it forms this bed for developing an infection. So dacryocystitis looks like this. You get this red, firm, tender mass right in the area of the lacrimal sac. Okay, sometimes if it's very tense, you can just stick a needle in it and drain it, and that'll help the patient feel better and help the abscess to resolve and get the antibiotic where it needs to be. So dacryocystitis can be from the most common organisms are strep and staph. Not surprising. I don't recommend, they talk about probing being, diagnostic. I don't recommend probing. These patients are very tender. I don't probe the nasolacrimal duct in adults in any circumstance. But again, you'll see this below the medial canthal tendon. Here's the medial canthal tendon. In the acute case, no irrigation. You just treat them with warm compresses, topical and oral antibiotics. Treat it like a preseptal cellulitis, basically. And the antibiotic choice, basically, you want something with wide coverage. Augmentin, Keflex. The book tells you a host of different antibiotics that you can use. And again, if there's an abscess, if this thing is very tense, if it's pointy and it looks like it wants to come out, you can stick a needle right in it and drain the abscess. You want to wait until the acute infection is resolved, and they pretty much always need a DCR surgery, a dacrocystic rhinostomy surgery, because once they've had these infections, it means that there is something abnormal further down in the system, in the nasolacrimal duct. And with these, especially patients with repeat episodes of dacryocystitis, they just have more and more and more scarring, so the system is just not patent. So these patients need to have a DCR, but do it when they're quiet. The one thing to make sure that you follow up on is these things can spread into the orbit. So if they have an infectious dacryocystitis, it can spread into the orbit because the bone separating, the lacrimal sac fossa and the orbit is very, very thin. And we've had several cases this year alone of infection extending into the orbit. So you want to make sure if they're being admitted to the hospital, follow them for orbital signs or give the patient verbal counseling regarding orbital signs like decreased vision, double vision, redness of the white part of the eye, all that good stuff. So just the schematic that Ray had put in here of a silicone intubation. Dacryocysto surgery is basically a fistulization surgery from the lacrimal sac into the nose. So you're bypassing not the canalicular system, but just bypassing the nasolacrimal duct. So everything from lacrimal sac above needs to be intact for this surgery to work. And this is just an endoscopic view. There are two ways to do DCR surgery, external versus internal. The external surgery, you're making an incision about 1 centimeter or maybe a little more, vertical incision right in the area of the lacrimal sac, making sure to avoid the angular arteries. The angular arteries are approximately 7 to 8 millimeters medial to the medial canthus, so you want to avoid the angular arteries because they can bleed. Then you basically open up, you're removing some of the bone that's encasing the lacrimal sac, exposing the sac, and you're opening the sac and opening the nasal mucosa internal to it, and you're just making this, splaying out both flaps and making a nice wide opening, and passing tubes through, so that you have tubes going through the canaliculi, through the common internal punctum. They just open out into the sac, which then just is widely open into the nose. Okay. You can do this endoscopically, as you can imagine, just in reverse order. So you go in through an endoscope, open up the nasal mucosa, you're looking at the bone that is encasing the sac, removing the bone, opening the sac, opposing the sac mucosa with the nasal mucosa, and then you're just looking at the internal punctum. Okay, and that's what it looks like. So this is a patient who is several months out from endoscopic dacryocysto surgery. This is now the new opening. These are the tubes that are coming through. This is the common internal punctum. And you can see that the nasal mucosa is pretty much healed in, so that you just have now this new opening that drains the tears. And this fluorescein was instilled up into the inferior fornix, and it's just draining through the system. Okay, and once the tubes are removed, you can see the fluorescein just comes in. So the last thing that we should talk about our lacrimal sac neoplasms. These are very rare. They usually happen in a slightly younger population, maybe in, I would say, 5th to 6th decade. And again, the most important thing to remember is that mass above the medial canthal tendon. Okay. They can present with bloody tears, bloody nose. They can have some skin ulceration overlying the area of the lacrimal sac. And if it's already invaded into the orbit, they can present with orbital signs, proptosis, diplopia, along with the lacrimal symptoms. CT scan, or I would say, or MRI, to forget the dacrocystography, whatever that means. CT or MRI would be the thing to order to get a better look. Here's an example of a lacrimal sac tumor that's invading into the orbit. They're always going to be in the infromedial orbit, as you can imagine, by contiguous spread. 45% of them are benign, so they're papillomas, so squamous papillomas. The squamous papillomas can be inverted or everted pattern. The inverted papillomas have a tendency to be more aggressive and to transform into a malignant lesion. So just remember that inverted papilloma have tendency to transform into a malignant lesion. When they are malignant, they're usually, as you can imagine, of squamous origin or transitional cell. So the last time we've all heard about transitional cell carcinoma was when we studied, histology of the bladder when we were second-year medical students. So you can think of the lacrimal sac like a bladder, right? It collects fluid, and at some point, the tendon squeezes and then it dumps the fluid out. It's kind of like how your bladder works. That's why you get transitional cell carcinoma of the lacrimal sac. There are others, but just remember squamous cell and transitional cell. The treatment is, like any cancer surgery, excisional surgery followed by adjuvant therapy. So I think this patient basically had a dacryocystectomy, so they removed the entire lacrimal system. Here's the nasolacrimal duct, all in one piece. If it's invaded into the orbit, then you may be doing an ethmoidectomy in the ethmoid sinus here, and a maxillectomy of the maxillary bone here, whatever you need to do to get a margin, okay? Often they will need to have radiation therapy following this type of radical tumor excision surgery. And then if they survive, you have to wait many years before trying to go in and reconstruct the system. It's like when you get a medial canthal, basal cell tumor that invades really deep, If you end up sacrificing the lacrimal system, well, and then the patient goes and has radiation and all of that, you have to wait several years before you go back and reconstruct the lacrimal system, just in case there's recurrence and you end up spreading or seeding other healthy areas.